Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. I'm your host, Patrick Hutzel is my name, and I'm here to answer your questions about if you have a loved one in intensive care, or if you have a loved one at home with intensive care at home, or if you're interested in intensive care at home. That's what I'm here to do. I do these YouTube lives every week around the same time. It's 10:30 a.m. now, Sydney, Melbourne time in Australia. It is 8:30 p.m. on a Saturday night, Eastern Standard Time in the US, and it is 5:30 p.m. Pacific time in the US. We also have some viewers from the UK normally. Currently, it is 1:30 a.m. in the UK, but the times will change as Australia and the UK go into daylight saving or stop daylight saving in the next couple of weeks. The same in the US, but it'll remain 10:30 a.m. Sydney, Melbourne time on a Sunday. Okay, and I will publish the times, the relevant times in the relevant time zones on my email invites. Okay, before we go into today's questions, I also want to welcome the viewers that watch this on replay. I know a lot of you are watching this on replay, so if you can't make it to the live stream, that's fine. If you can make it to the live stream, that's a good opportunity for you to ask questions. You can also join me live on the StreamYard link here that I posted in the chat pad. If you want to talk to me directly and ask me questions here one-on-one, you are more than welcome to. If not, you can type your questions into the chat pad. Also, if you like the work that I'm doing, subscribe to my YouTube channel, give the video a thumbs up, but subscribe to my YouTube channel for regular updates and for the YouTube lives for families in intensive care and intensive care at home. Click the like button, share the video with your friends and families, and comment, of course, what you want to see next, what questions you have, and so forth. Now, what makes me qualified to answer questions for families in intensive care? Well, I'm a critical care nurse by background. I have been working in critical care for nearly 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. And I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can confidently say that we have saved many lives with our consulting and advocacy. Just one recently, but I'll come to that in a minute. And we have many testimonials on our testimonial section at intensivecarehotline.com. And we also have interviews with our clients on our podcast section at intensivecarehotline.com. Now, I'm also the founder and managing director and CEO of Intensive Care at Home. With Intensive Care at Home, we are sending our critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies, but also for otherwise medically complex adults and children at home on BiPAP, CPAP, tracheostomy without ventilation. And we are very successful there. We are operating all around Australia with intensive care at home in all metropolitan areas, regional as well as remote areas. And we employ hundreds of years of intensive care nursing skills combined in the community, which enables us to bring the highest skill levels in the community. And there's no other provider in Australia that looks after a higher acuity in the community. We are third-party accredited, and we are NDIS accredited, TAC and WorkSafe in Victoria, ICare in New South Wales, and NIISQ in Queensland, as well as the DVA. Now, without further ado, let's start with the testimonial that came in during the week. We were working with a client in the UK a couple of weeks ago, where the client's brother was in ICU on a ventilator with a pneumonia. The client's brother has Down syndrome, but had a good quality of life before he went into ICU. And ICU was adamant to withdraw life support because, they felt like even if the client's brother was to survive, that he won't have any quote unquote quality of life. Well, what is quality of life? That is just a perception. And I went on a phone call with the ICU consultant, and obviously I was advocating with the next of kin, and lo and behold, the ICU changed their tune and decided, to continue treatment. Not that it was up to the ICU anyway. It's always up to the family or to the patient to determine what the next steps are, right? But it is always good if everyone is aligned and if everyone can be on the same page. That is certainly very helpful in situations when you have a loved one critically ill in intensive care. Okay, so that was the good news from this week. There have been many other good news, but let's just start with questions that came in during the week and that I will answer now. And in the meantime, if you have questions, please type them into the chat pad or join me live on the StreamYard link here by clicking on the StreamYard link that I just posted in the chat pad here. And let's continue with the first question. From Roger, who says, "Hi Patrick, can you provide me with a list of questions to ask to LTACs? The ICU says that my mom needs to go to LTAC next week. She will be on a tracheostomy ventilation. She will go on the tracheola sometimes, and they reckon she will be on the ventilator for at least another week. She was on the tracheola, no ventilator, on 70% of oxygen for about 8 hours during the day on Thursday. During when she went to sleep, she went back on the ventilator with assistance, probably on a PEEP of 5, pressure support of 5, at 40 or 50% of FiO2. Can you please share questions, what to ask an LTAC before she goes there?" Well, Roger, thank you so much for your question. And before I go into the questions, what to ask an LTAC, the biggest question here is, how can you avoid LTAC? I mean, I've been preaching this for the last 10 years, that going to LTAC is not a good idea. Going to LTAC is futile. Going to LTAC is like going from ICU to a nursing home, right? That's what LTACs are. They're not even the beta version of a nursing home, no matter what people will tell you, no matter what people write on their website, that they're specialized in, ventilation weaning. We are at the cold phase, and we talk to families who see our information too late and who see that their loved ones shouldn't have gone to LTAC, but when they go to LTAC, that's when they start doing the research, because they realize something's going horribly wrong, right? Something's going horribly wrong, and they realize that LTAC is a very safe, it's a very unsafe place for their family member and for their family, because they realize that the staff there have no skills to look after ventilator and tracheostomy, let alone wean them off it, right? There might be the exception to the rule. I just haven't found it. And instead of, and I will go through the questions what to ask an LTAC, but instead of asking the LTAC, what the questions that you want to ask them, your time is better spent keeping your mom in ICU and making sure she gets best care and treatment there. We have helped many clients over the years staying in ICU in the US. I mean, LTACs are unique to the US, as we know. And we have saved many clients by keeping them in ICU with our advocacy and making sure they get the best care and treatment in that ICU rather than going to LTAC, right? We also have some testimonials around that. So let's look at the questions you should be asking, Roger. Ask them, what specifically will LTAC provide? Are they providing ventilator weaning, rehabilitation? But I can also say to you, have a look on their website, see what they claim they do, and look at the online reviews from families. And I can guarantee you, there's a big discrepancy between what the LTAC says on their website they can do between what families report in their reviews. I can almost guarantee you that. Also, next question. Is the care plan individualized for each patient? Are they individualizing a care plan? If they say yes, how are they going to implement the care plan and who's going to be held accountable for it? Right? Next, are all your nurses ICU trained? Are all your nurses ICU trained, and are they ventilator and tracheostomy competent? Once again, from my extensive experience, they're not. They're not. Here is why ICUs are pushing from ICU to LTAC as quickly as possible. Well, it's a money-saving exercise for the insurances. The pathway is to get a patient out of ICU as quickly as possible once they have a trach and a PEG. And it's a money-saving exercise, no more than that. It's how the system is designed. It is not to provide best care and treatment for a patient or for a family. It's all about saving money, right? But you have the, you have the know-how now to not go to LTAC in the first place, which leads me to my next point. Care needs to be evidence-based. So, for example, if they have no ICU nurses, no ICU doctors, it's not evidence-based, right? Keep in mind, your loved one is on the verge of going from ICU to LTAC. He's at their most, your loved one is at their most vulnerable they can ever be, right? And then you're sending them to LTAC. That is just absolutely crazy, right? That is just absolutely crazy. It's a bit like flying the airplane with a cabin crew instead of with a pilot. So what do I mean by that? When you're going from ICU, where you have ICU doctors, ICU nurses, in the US you have respiratory therapists, and then you're going to LTAC, all of a sudden you've got the cabin crew at best. With over the years when we work with clients and I spoke to LTACs and I asked questions to LTAC staff, whether it's nurses or RTs, they have no clue what they're talking about. No clue, right? So no surprise that patients and families are not getting the best care and treatment. No surprise that patients and families in LTAC are screaming out, "Get me out of here." Right? That is just the unfortunate reality you are dealing with. Right? Which leads me to my next question that you should be asking if you are contemplating of getting a loved one to LTAC. The next question is, are they on a 30-day time window? So what do I mean by that? A lot of LTACs do not tell you that when they go to LTAC, there's a 30-day time window, and if your loved one isn't improving, they will then be sent to a skilled nursing facility where it's getting even worse, right? So do not, your time is best spent making sure your loved one continues to get best care and treatment in ICU. That's where your time is best spent. Helene is saying crazy, or would make you go crazy. Yeah, for sure. Absolutely. The next question you should be asking is, what are your weaning plans? What are your success rates for the weaning? Right? Ask them that. And ask them that you can talk to referees, i.e. other families. Ask them that. Right? Next, how do you prevent pressure sores or bed sores? Well, the answer to that needs to be something along the lines of, well, we mobilize our patients every day. Right? That's where the answer needs to go to straight away. That's how you prevent bed sores, by mobilization, by turning patients from side to side regularly. But the best prevention for pressure sores is actually mobilization and physical therapy. Right? Also, the next question, are ICU doctors available 24 hours a day? Right? And ask about their weaning schedule. What's their plan? Let them talk you through it step by step, how to wean your loved one off the ventilator. If they can't do that, you're in the wrong place. You're in the wrong place. Next, what is the nurse to patient ratio? I.e., how many, if there's one nurse, how many patients are they looking after? Right? If there's one nurse, how many patients are they looking after? Get that number from them. And I can assure you it's going to be 1 to 4 at best, probably something like 1 to 5, 1 to 8 overnight, potentially 1 to 10. That's crazy. That is crazy. Your loved one goes from ICU, from 1-to-1 nurse to patient ratio with doctors, RTs, and so forth, to a facility where they have no ICU nurses, no ICU doctors, and you have a 1-to-1, a 1 to 4, 1 to 5, 1 to 10 nurse to patient ratio, right? But the problem here is not so much that this is happening. The problem here is that families don't do their research. The problem is that families just give in. That's the problem. You know, the system is the system, but you need to fight the system, right? Next question. How frequently is your loved one getting showers or at least bed baths, right? Don't let them make excuses that just because your loved one is on a ventilator with a trach, that they can't shower then. You know, ICUs that I worked at, we showered plenty of patients, even if they were ventilated with a trach. In intensive care at home, all of our patients have showers at home, right? Even though they're ventilated with a trach, right? So don't let them tell you or convince you otherwise. Next question, what are visiting hours for your relatives? Or what are visiting hours for you? Also, what if a patient is, you know, confused, potentially aggressive? What do? Will they restrain them? Will they restrain them chemically? What are they doing? Right? So these are questions you need to ask. Right? But I tell you, the most important questions out of all of those questions are your nurses having ICU experience? Because if they don't, forget about it. Forget about it. You'll be making your loved one very, very unsafe. Very, very unsafe. Right? So also, how they handle emergency situations is another question that you need to ask. Right? How do they manage emergency situation? Do they have the skills? Also, what if your loved one deteriorates? God forbid. What if your loved one deteriorates? Needs inotropes, needs vasopressors, needs blood transfusions. What are the next steps? Can they handle that? Right? Do they have chest X-ray services on site? Do they have pathology services on site? Right? Pharmacy on site? Right? Do they have a plan to wean off the PEG, i.e., do they have a plan to restart feeding, oral feeding for your family member and wean off the PEG? Right? Also a very important question to ask. Now, next, you know, the other thing that we've seen over the years is when patients do go to LTAC, right, they often, hospitals often want to send them away, hours away from the discharging ICU. That is crazy, right? We've seen clients or ICUs wanting to move clients 2 hours away, 4 hours away, often in another state. That is just madness, absolute madness. Why would you sign up for something like that? You know, keep your focus on making sure your loved one gets best care and treatment in ICU. Keep your focus on that. And like I said, we've had a number of clients where we helped them to stay in ICU until they were weaned off the ventilator. So it's definitely possible. Don't let anybody else persuade you. Otherwise, if ICU tells you, oh, your mom, your dad, your family member must go to LTAC next week, I call nonsense on that, because no one can discharge your family member without your family members' consent if they can't give consent themselves, without your consent, assuming you are the next of kin or power of attorney. Common sense. Always bring it back to common sense here. So those were the questions to ask. If you have what questions to ask if you are considering going to LTAC, but don't consider it. Do not consider it, ever. Okay, now, if you have any questions, type them into the chat pad or join me live on the StreamYard link, right? I've posted the StreamYard link here. We can focus on your questions only here, and we can focus on them really well. If you have no questions, I will move on to the next question that comes from Bannister, who says, "Hi, Patrick. We are hanging in there. As predicted, my mom went to LTAC and it was very traumatic and destabilizing. She has side effects from fentanyl and moderate sedation, chemicals that can take days to filter out. She definitely looked worse the first day in LTAC, and her vitals were worse than the day before. The transfer was very cold outside, snowing. Even though I explained and consoled her ahead of time, on the morning of the transfer, she had high anxiety, very high heart rate, high blood pressure, AFib, irregular heart rhythm, nausea, pain, shakiness, red blotches, etc. She woke up crying today with abdominal pain. Luckily, my sister was there and got us quick help. Unless the pain happens to ping the vitals, it's a good thing when we're there to get the help. The nurse figured it out. The PEG tube insertion area is inflamed. They cleaned the area, gave Tylenol, and will contact the doctor to order bacitracin gel. And they will give stronger pain medications later if needed. Now, the trach moved by about 1 inch last night. Luckily, we could alert the nurses and they put it back in. The nurse fixed it. The trach oxygen to device hose support stands missing parts and no support option on bed. We'll mention to the doctors on Monday. The RTs don't seem to be concerned. I think it's adding weight and pulling the trach to the side. There's blood coming out into the suctioning tube during the suction process, which is probably a direct result of no support option on the hose or the circuit, right? That's again is a sign that you're dealing with amateurs and not professionals. Because if the trach collar is pulling weight on the trach, of course, it's prone to bleed. And that's probably also why it came out by a centimeter, the trach. Here's a text from my sister from today when she was there with my mom in LTAC. They stopped the feeding last night for a while due to nausea. They gave Sofran, gave Ativan for anxiety. They drew blood from the left arm, the IV side, for urea, creatinine, bond levels, hemoglobin, white cell count, and other pathology levels. 9:15 a.m. Severe urinary pain, urinalysis sent, adjusted urinary catheter. The blood pressure shot up to 190 over 100 after having improved to 157 over 70. They will give Ativan. 8:30, taken off the ventilator, put on humidified oxygen. Anthony, the RT, dropped suction on the floor, then was going to suction the mouth with it. I said it was okay because it was going in the mouth. I shook my head, no. Rightly so, well done. If it drops on the floor, it needs to be thrown out. He said there were no more on this floor, then went and got some. 8:40, Dr. Pearson and Anthony changed to a smaller trach tube, size 6. It should be more comfortable. They will insert a speaking valve today, if she does good with that. They may change to a smaller size 4 or size 5 tube in the future. They asked the RN Karen why systolic blood pressure is always high. And the answer was if they give too much hydralazine, it could drop the blood pressure too much. Yeah, you got to find the happy medium. You got to start some regular antihypertensives to get the blood pressure to a range that is acceptable for everyone. However, a lot of the discomfort could simply be coming by being in an LTAC and by not being in the right place. So the question here is your mom in the right place? And I can almost tell you she's not. We can already see that by the email. They're also giving diuretics for edema and continuing to give blood thinners. And I know that this client or this email comes from a patient who has atrial fibrillation or AFib, which is why they would need to give the blood thinners. Then he continues, Bannister continues. As we were transferred into Northern Colorado long-term acute hospital on a Saturday, I believe I'll be able to find out much more how things work here tomorrow on Monday. It's the big company thing. Ask 3 people the same question and I might get 3 different answers. I can call in, or when I'm on site, I can ask some questions about vitals. There might be non-electronic paper-based options, which might be daily, that I can sign up for on Monday. If it works out, I could send you a daily scan of the pages. Sure. Look, Bannister, you should get access to the medical records, but it should not be them printing out papers. In this day and age, it should all be online, right? You should just get a link to a website or a link to an app with a username and a password, and then you should have access to the medical records. That's it. Should be no more complicated than that. Then Bannister continues. They are continuing a weaning process, trachea and oxygen during the day, ventilator support at night, experimenting with speaking valve. I need to get up to speed with any of your videos and articles that you have published about trach management and ventilator weaning. I'll be with my mom for maybe 8 hours on Monday. Good time to watch and read your info. By the way, whenever they mentioned training, it was only given to my mom, not to the family. Tracheostomy teaching completed this date, included from Bannister. Well, Bannister, you already know you're in the wrong place, right? I would try and get your mom back to ICU unless she's making some rapid progress, right? She's making rapid progress and she can wean off the ventilator. Maybe she has a small chance, but things like if the suction catheter drops on the floor and they see no need to replace it, for example, you're dealing with amateurs and not professionals, and that should very much concern you, right? So, and also if the PEG tube is inflamed, right, that is also a concern. And once again, I would never ever give consent to a PEG tube. Yes, that leads me to another point here. If you're in ICU, if you have a family member in ICU in the US specifically, and ICU is pushing you for a trach and a PEG, if your family member can't come off the ventilator, a trach is probably the right thing to do. But under no circumstances should you give consent to a PEG tube. Under no circumstances. And because if you give consent to a trach and a PEG, ICU holds all the cards, which means LTACs are ready to take your family member with a trach and a PEG. If you're not giving consent to a PEG, ICU can't send your loved one to an LTAC because LTACs will not take a patient with a trach and a nasogastric tube. They just won't do that, right? So there are some stops that you can put in. One of them is not giving consent to a PEG tube. But even if your loved one stays in ICU, do not give consent to a PEG tube, ever. There are exceptions to the rule, and the exceptions are that when patients have shown the inability of weaning off the ventilator and they need to stay on the ventilator for the rest of their life, so whatever reason, that is when you can confidently give consent to a PEG tube. But most patients have the ability to come off the ventilator, therefore you shouldn't give consent to a PEG tube, right? Also, with this email from Bannister here, right? High heart rate, high blood pressure, AFib, atrial fibrillation, irregular heart rate, nausea, pain, shakiness, red blotches. You know, letting your mom go from an ICU to an LTAC in a situation like that is just sheer and utter madness, right? One more word to PEG tubes. Please also keep in mind, if you are giving consent to a PEG tube has the perception in the healthcare industry that it's permanent, and no further attempt are often made to remove the PEG tube and to start the patient on oral feeds again, right? So with that said, with all of that said, with a nasogastric tube, it has the perception of it's temporary, i.e. people, doctors, nurses need to start to wean aggressively the ventilator and the trach so that the nasogastric tube can be removed, right? That needs to happen automatically, right? Whereas in LTAC, there's no sense of urgency. You need to create a sense of urgency when it comes to ventilator weaning, but you need to create that sense of urgency from day one, right? So that the narrative around needing a tracheostomy can't be created, right? The narrative that you need to create from day one is wean your loved one off the ventilator. That's the narrative you need to create, right? So, you know, so you need to get this right from day one. This is your problem, that, you know, you don't know what you don't know. Biggest challenge for families in intensive care simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That is your biggest challenge, right? In the meantime, before I go on to other questions, if you have any questions, type them into the chat pad or join me live on the StreamYard link here. You can join me live on the StreamYard link. If you click on the link here, your questions are welcome. If not, I'll just post the StreamYard link in here again. Now, next question is coming from Deborah, who says, "Hi, Patrick. I need to talk to you because late on Wednesday, late tonight or tomorrow morning, they want me to come in tomorrow to continue to harass, pressure, and bully me into consenting to transfer to an LTAC because they're saying that my mother is," and Deborah puts this in quotes, because they're saying my mother is medically ready and stable. I've stalled them for a few days already using Patrick's first idea about saying to look at more LTACs. The insurance authorization to LTAC expires tomorrow, so they're turning up the heat. In addition to my mom in the hospital on the ventilator, my dad recently had a fall and went from independent to needing me to transport to the commode and clean up to 8 times every 24 hours. I have too many issues in life at the same time. So, and this Deborah also sent me a link to the medical records here. Okay, great. So, well, here's the good news, Deborah. You don't have to go to a meeting, right? You don't. And no one can force you to go into a meeting, right? And just stick with that. It's very simple. It's very simple. You know, one thing that I've learned is ICUs are very repetitive in what they want, right? And families think because ICUs are repetitive that they need to give in. Well, my answer to this is you can be repetitive too. You know, play the same game. Play the same game. Tell them what you want. Tell them what you want in no uncertain terms. And don't go to meetings. Put things in writing, rather. Put things in writing, rather. That's what I would do. Okay, now, in the meantime, type your questions into the chat pad or join me live on the StreamYard link here. If not, I will move on to the next question, which comes from, need to give me a second. I just need to scroll through my questions. I do apologize for the delay. Just got to go through. Oh, sorry. Okay, so in the meantime, yeah, just repeat while I'm looking for my next question. Do not give consent to a PEG tube. A trach might be fine, but before you give consent to a PEG tube, you should also check out an article that I've written and a video that I recorded, how to wean a critically ill patient off the ventilator and the breathing tube. That is one of the most important articles that I've ever written, because if you can avoid the trach, that is your best bet. That is your best bet, right? Now, also, let's move on to the next question from Cindy. Hi, Patrick. Thank you for all your videos. My family member had a heart attack and his wife woke up in the middle of the night with him struggling to breathe. She thought he was having a nightmare and tried to wake him for a minute or so, but then called 911. They told her to start CPR immediately. He started to turn blue when she started. The paramedics were there within 11 minutes of her doing CPR. Here we are at day 4 with all his organs doing fine, but waiting on an MRI scan of the brain. Your video gave me hope. I'm not sure if it's in an induced coma or not. What's the difference? Right? So, first off, they should be doing an MRI scan or a CT scan of the brain as quickly as possible to ascertain whether there is any further brain damage. Right? That's number one. Number two, if the paramedics were there within 11 minutes of your family member doing CPR, there's a chance that, there may be some brain damage depending on the effectiveness of CPR, whether your family member was effectively doing CPR or whether it was not effective, right? But that is also why they need to do the MRI scan or the CT scan to find out how effective it all was, right? So, next, MRI scan, CT scan of the brain needs to happen to make sure there is no brain damage. Whether your family member is in an induced coma or not, I'm not sure. I can't tell you. I tell you what the difference is. So let's just say your family member, God forbid, has brain damage and is ventilated with a breathing tube, only 4 days, right? Chances are he is in an induced coma if he doesn't have any brain damage, because it would be very difficult for him to tolerate the breathing tube. If, on the other hand, he has brain damage, God forbid, then he may actually be in a natural coma, right? So you need to find out which one it is, right? You need to find out which one it is and ask the question. If he is in an induced coma, that may not necessarily be a bad thing because it means there's brain function most likely. Right? So what needs to happen next? If all his other organs are fine, that's good. What about the heart? I mean, he had a cardiac arrest. What about the heart? Right? That's one question. What about the brain, of course? Has he been seen by a cardiologist? Why do they think he had a cardiac arrest? Has he had an angiogram where they screen the coronary arteries, the arteries around the heart, to make sure there's no blockage? Have they done that? Right? So those are really important questions you need to ask. What are the kidneys doing? Even though you're saying all other organs are fine, I would find out what the kidneys are doing. I would try and do that because the kidneys can often be impacted. Okay, let's move on to the next question. And if you have any questions, type them into the chat pad or join me live on the StreamYard link here directly, and you can ask me questions here, right? But when a patient goes into ICU with cardiac arrest, and they had some CPR, prolonged CPR, there should be an MRI or a CT scan done straight away, right? And if he can't have that, I wonder whether he's in a good ICU, whether your family member is in a good ICU, right? Or whether he's in an ICU where they don't have the knowledge, the skills, the equipment to do what is needed, right, in a situation like that. Okay. Let's move on to the next question from Diane. Before I read out Diane's question, if you have any questions, type them into the chat pad or join me live on the StreamYard link here and talk to me directly. Okay, Diane says, hi Patrick. Doctors are writing off my husband because of his previous stroke and bleed history, which was caused by a hospital anesthesia error, which due to lack of therapy has left him immobile, requiring 24-hour care. Although he is immobile, I feel that he's immobile due to lack of therapy as opposed to being immobile because his brain is not functioning properly. After 2 days in the ICU where they ventilated him, on arrival, because they said he wasn't breathing on his own, although prior to his ambulance ride when he vomited again, his pulse oximetry was around 89 to 92%. So I assume more vomit went into his lungs as he was having a pneumonia, which they are treating. They're recommending a tracheostomy before knowing if he will be able to breathe on his own once the pneumonia resolves and before the blood from the bleed is reabsorbed when they could fully access his body's abilities to function properly. Yeah, absolutely, Diane. Here's the first question that you need to ask whenever ICUs bring up a tracheostomy as an option. The first question that you need to ask them is, how are you planning to avoid the tracheostomy? The next question you need to ask, and like I said, I can only point you back to one of my articles that I've written, how to wean a critically ill patient off the ventilator and the breathing tube. That is one of the most important articles that I've ever written. Go to our website, intensivecarehotline.com, and type this into the chat pad. You will get to the article, how to wean a critically ill patient off the breathing tube and the ventilator. Type it in or type it into Google, intensive care hotline, how to wean a critically ill patient off the ventilator and the breathing tube, and it'll point you to it. Next. They should absolutely be treating the pneumonia, and hopefully the antibiotic therapy is going to be effective, right? And they should be, in the meantime, what's their plan of weaning your husband off the ventilator? What's their plan, right? Can they wake him up? Stop sedation as quickly as possible, especially since he's got a brain bleed as well, right? They should stop sedation as quickly as possible, and especially with a brain bleed. right? So, but it's interesting that just because he's immobile, that they weren't going to do any physical therapy. So physical therapy needs to start on day one when you have a loved one in ICU, notwithstanding if there are fractures, of course. But if there are no fractures, you need to move arms, legs, fingers, even your joints, so they're not getting rusty, they're not getting contracted. One of the biggest issues for ICU patients is every day someone is in an induced coma, they are declining, right? So you need to start moving patients as quickly as possible, including physical therapy. And like I said, even if it's only moving the joints, even that is important. The last thing that you want is your loved one coming out with contractions. That is the last thing that you want. Right? And yes, the blood from the bleed needs to be absorbed, but the question is, has there been any irreversible brain damage done? You got to picture this when, blood is entering the brain, it's killing the brain cells, unfortunately. And it's often killing them irreversibly. Right? Irregardless, you should be asking for what we discussed. You should be asking for physical therapy. You should be asking for efforts to avoid the tracheostomy. Right? You should absolutely be pushing to avoid the tracheostomy. Right? So, then moving on to the next question, or before I move on to the next question, type your questions into the chat pad or join me live on the StreamYard link that I posted into the chat pad here. I welcome your questions. If not, I've got plenty of questions sitting here, but this is your opportunity to talk to me directly and get your questions answered live on the show. So, next question comes from Alexandra, who says, "Hi Patrick, I came across your videos on YouTube and I was wondering if you could help me by answering some questions. My father suffered a massive heart attack last week ago. He was put under sedation since that day. He had an impeller device put in his heart to open up a blocked artery. All went well. His heart is good." Well, an impeller device, just for those of you who don't know what an impeller device is, an impeller device is actually like an RVAD or an LVAD, which can take over the function of the heart for a period of time. Right? Let's continue her email to see what the full story is. He was also put on a ventilator yesterday. They started to wean him off sedation medication to get him extubated. That's how it should be. Wean him off sedation to get someone extubated. That's how it should be for pretty much every patient in ICU. He was not fully awake and alert. They pulled the ventilator out but ended putting it back in because my dad was in a delirious state. He was very agitated. The sleeping meds went back on and he's out of it again. Today they told me they want to keep him sedated for a few more days to slowly wean him off. Does that sound right? I'm asking for a different approach this time around. Half the nurses are clueless and the other half are telling me different things. As far as the ventilator goes, it's on spontaneous mode and Dad is breathing on his own. To me, it sounds like he's ready to be woken up, but the ICU is taking their sweet time. What do you recommend we as a family demand? Is being on sedation medication for 7 days too long? Is being on the ventilator for 7 days too long? Thank you, and I hope to hear from you soon. Going to see my dad again tomorrow morning, from Alexandra. Okay, well, there's a number of things here, right? He's got an impeller, which means his heart must be very weak, right? So it's not unusual that the first attempt of extubation may fail, right? If the first attempt of ventilation may fail, yeah, by all means, resedate for a little while, but then wake up the patient again as quickly as possible and try again to extubate the patient, right? But the question is, what's happening with the heart, right? How strong is the heart? What's the impeller doing? Because I'm wondering whether, whether it's got everything to do with the heart, that your dad is not coping to get off that ventilator, right? So is the impeller potentially not doing its job? Have they done a chest x-ray? Have they done an ultrasound of the heart? And here is why. An ultrasound of the heart will tell you, how strong is the heart beating, especially with the impeller pump, right? So question is, why did your dad fail? Was he simply too sleepy? Was he not ready? Why did he fail extubation? Is it the heart? Is it the lungs? Is it something else? Right? Is the impeller pump working to the extent it needs to work at? Right? And to answer your question, is being on sedation medication for 7 days too long? Is being on the ventilator for 7 days too long? The answer to that question is that it depends. Some patients need to be on the ventilator for 7 days. For example, if someone has multiple trauma, and they're waiting for surgery and they might have even lung trauma and all the rest of it, 7 days on a ventilator is not too long, right? In your dad's case, again, what's the heart doing, right? And the question also is, what if they can get him off within that 7 day period, right? Then I'd say 7 days is not too long, right? You need to speak to a cardiologist and you need to speak to the intensive care team here to find out what is exactly going on. Is the heart attack potentially stopping your dad to be weaned off the ventilator, right? Even though he's got the impeller pump. Also, what's the plan with the impeller pump? Most impeller pumps that I've seen is it can only be temporarily. It should only be temporarily, right? It should only be to get the heart stabilized, right? Regain some of the ejection fraction. Your dad's ejection fraction is probably very low, right? Ejection fraction stands for the contractility of the heart, for the pump function of the heart, right? With the pump function of the heart potentially being weak, that's when you need an impeller pump, right? So, but where does that lead to? Does it lead to giving inotropes such as milrinone, dobutamine, levosimendan, and then taking the impeller out? Or does it potentially lead to a heart transplant? What is the plan? Right? What is the plan? Ask them. I'm sure they haven't mentioned anything about ejection fraction yet, because I'm sure you would have mentioned it. It's a very important question to ask for anyone who's had a heart attack or a cardiac arrest, to find out what the ejection fraction is. Once again, ejection fraction is the pump function of the heart, the contractility of the heart, and I bet it would have been very poor in the beginning. That's why they implanted the impeller, who takes over some of the pump function of the heart, right? So I've got another 5 minutes left. I've got plenty of questions to go through still. If you have any questions, this is your last chance to ask me a question here, live on the show. Or if you can also join me live on the StreamYard link here. But I do those YouTube lives weekly, every Sunday, 10:30 a.m. Sydney, Melbourne time, which is currently 8:30 p.m. Eastern Standard Time on a Saturday night in the US, 5:30 p.m. on a Saturday Pacific time. Next week, the times will change. It'll still be 10:30 a.m. Sydney, Melbourne time, but it'll be 7:30 p.m. Eastern Standard Time and 4:30 p.m. Pacific time on a Saturday. simply because we are going into daylight saving here, right? So, but we will announce the right times when we send out our emails to our email subscriber list for the YouTube lives, right? Okay, so yeah, this is what you need to do in this situation, Alexandra. Ask the questions, get the cardiologist involved, right? And ask them how to wean him off the ventilator without the trach. Here is another risk that I can see with the trach in this particular situation. So with your dad being on the impeller pump, he is most likely on a heparin infusion, right? Heparin is a blood thinner, right? And putting someone on the impeller without a heparin infusion would most likely spark a blood clot, right? Causing brain damage, causing a pulmonary embolus, and the list goes on, right? Heparin is a contraindication to doing a tracheostomy because of the risk of bleeding. Unless they can stop the heparin for a few hours to do a tracheostomy, which is a massive, massive risk, to stop heparin while your loved one is on the impeller pump. In any case, I got to wrap this up here. Thank you for your support. Thank you for your attention. Thank you for your question that you've emailed in. I always prefer talking to people live here on the show, but not today, obviously. Plenty of questions coming in. If you like my videos, click the like button, subscribe to my YouTube channel, share the video, and comment below what you want to see next, what questions and insights you have. We have a membership for families of critically ill patients in intensive care at intensivecarehotline.com, where you have access to me and my team 24 hours a day in a membership area and via email, and we answer all questions intensive care related. And you can get access to the membership if you go to intensivecarehotline.com, click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you also have exclusive access to 21 ebooks and 21 videos that I've personally written and recorded. And all of that will help you to make informed decisions, have peace of mind, control, power, influence, making sure your loved one gets best care and treatment. I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I handhold you through this once-in-a-lifetime situation that you can't afford to get wrong. I also talk to doctors and nurses directly. And when I talk to doctors and nurses directly, I ask all the questions that you haven't even considered asking. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. And all of that you get at intensivecarehotline.com. With Intensive Care at Home, like I said, we're currently operating all around Australia and all major capital cities, as well as in all regional and rural areas. We are NDIS approved all around the country. iCare in New South Wales, TAC and WorkSafe in Victoria, NIISQ in Queensland, DVA all around the country. Our clients have received funding through public hospitals, private health funds, as well as departments of health. Also, we're providing level 2 and level 3 NDIS support coordination. If you are an NDIS support coordinator and you need help with your clients, we also do NDIS nursing assessments. Please reach out to us. If you need help with funding, if you need nursing care for your clients, please reach out to us. And lastly, if you're at home already and you need intensive care at home, please reach out to us. Don't worry about funding. We can help you with funding. Otherwise, we wouldn't be in business. Now, I got to wrap this up here. Like the video, comment below, share the video with your friends and families, and subscribe to my YouTube channel. Thank you so much for watching. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I will talk to you again during the week. Take care for now.